Good morning, good afternoon, good evening, and welcome everyone. Thank you for joining us for today's webinar from different regions of the world. My name is Christine, and I'm your hostess for virtual courses from the Forum of Adipose Tissue and Stem Cell, or better known as FATS. So as you're familiar, FATS is an academic facilitator that has functioned as a driving force behind a number of high-profile conferences in Southeast Asia since 2009. We provide an academic platform to better understand the significance and uses of stem cell science in both aesthetics as well as regenerative medicine. With great honor, our founder, Mr. Eddie Liu, is here with us today. May we have him up on the screen just to welcome everyone, please. Mr. Eddie, you're up.
You need to unmute yourself, Mr. Eddie. Okay.
Dear esteemed doctors, a very warm welcome to all of you from around the world. I am Mr. Eddie Liu, founder for FATS, better known for Forum of Adipose Tissue and Stem Cell. FATS was founded in year 2009. We serve as a dedicated educational platform in the field of regenerative medicine and surgery. For the past 12 years, FATS have hosted many renowned experts from all around the world on our annual FATS Bangkok on-site conference. Tonight, we are very honored to host FATS PRP webinar series led by Professor Guy Magalon from Marseille, France, with his team of distinguished faculty. Moving forward, FATS will host most webinar virtual learning, bringing you only the best experts in this field of medicine. I would like to thank all of you for taking your precious time to join us tonight. Please enjoy the webinar. Thank you.
Thank you, Mr. Eddie. Today, FATS working hand in hand with our main sponsor, Fidia Pharma, a leading Italian pharmaceutical manufacturer, and our gold sponsor, Horiba Medical, a world leader in hematology market. We from FATS, Fidia Pharma, and Horiba Medical proudly bring to you our very first introductory webinar with the title, The Application of Platelet-Rich Plasma in Regenerative Medicine, moderated by none other than Professor Guy Magalon, and presented by our prestigious speaker, Dr. Jeremy Magalon. So today we are going to learn about what is PRP, the science, the protocol, the indication, and more importantly, the contraindication of PRP, and finally, the application of PRP in regenerative medicine procedure. Following tonight's introductory lecture, we have also prepared 3 other very exciting consecutive virtual sessions on additional application of PRP. The first session is going on the 20th of June in dermatologic practice. The second session will be on the 27th of June. Very interesting application of PRP for female and male genital areas. Last but not the least, the third session of the full series will be on the 4th of July with the use of PRP for orthopedic as well as sports medicine. Now for tonight, we have a series of exciting agenda lining up for you at the end of this webinar, which includes an exclusive promotion for our upcoming PRP courses and complimentary giveaways that will be given out as finale. So stay tuned with us till very end, ladies and gentlemen. So just a little housekeeping before we start our lecture tonight. If you have any questions during the presentation, please type them into the question box in your Zoom control panel. So if you take a look around your screen, you should be able to locate Q&A button either at the bottom or on top of the right-hand side of your screen, depending on what gadget you're using to log into this particular webinar. So look for Q&A icons, click on it. You can type in your question or about. We will compile them and bring them up to Professor as well as Dr. Magalon, dedicated at the end of the webinar for all your questions. Now, allow me to introduce Professor Guy Magalon, our key moderator today. Professor Guy Magalon is a board-certified plastic and reconstructive surgeon with more than 40 years of experience in Marseille, a really beautiful city from southern France. Professor Magalon holds a deep passion for cell therapies, and he is the pioneer of regenerative medicine in development of adipose tissue transplantation, along with the use of stem cells for the management of debilitating chronic diseases, right? So he is also the president of the Foundation de l'Avenir, whose ambition is to fund the most promising clinical studies of the future. Professor Guy Magalon is the founder and also the president of ISPRESS, which also stands for International Society of Plastic Regenerative Surgeon. Prof. Guy Magalon is also the founder and president of RAMDEX in France, the first logistic and technical platform for doctors who wish to perform regenerative medicine procedures, where this very platform enables so many doctors to perform regenerative medicine procedures under rigorous medical and scientific conditions. So without further ado, Professor Guy Magalon, ladies and gentlemen.
Yeah. Okay, I want just to talk about platelets. Platelets are very small cells, about 2 micron in diameters, and normal platelet count is from 150,000 to 450,000. They can be non-activated and activated, and platelets are the cell that circulate within the blood and bind together when they recognize damaged blood vessels. A blood vessel sends a signal, and the signal informs the platelet to go to the wound and to repair the wound. Because platelets, they contain more than 30 bioactive proteins who are active in all the field of hemostasis and tissue healing. For platelet-rich plasma, it's a blood harvesting with anticoagulants. When you have the blood, you go to centrifuge, and you have the way to have a differential centrifugation, and the cell will be separate. You have at the top the platelet, in the middle the white cell, and in the back the red cells. And at the end you obtain this product. This product is a PRP. Here it's a pure PRP because you see it's light and yellow, and is the product that we use when you want to treat patients, because you have no contamination with white cell and red cell. And now I want to introduce Jeremy Magalon, who is a biologist. He is a researcher, and he has a lot of experience in the product, and he will show you all the problem with PRP. And Jeremy, you can start your presentation.
Is it fine? Okay. So, dear colleagues, it's a great honor today to be there and to share with you my experience in the field of regenerative medicine and about PRP. So, I'm Jeremy Magalon. I'm PharmD. I'm PhD. I'm working in a university hospital in Marseille, in the south of France, in a department which is called the Cell Therapy and Regenerative Medicine Unit. Today, I will try to make a broad approach about what is PRP. So it's an introduction and basic knowledge in PRP use. And I hope you will learn everything you need and you want. So this is the plan of my talk. I will explain you what is the place of PRP in the world of cell therapy and regenerative medicine, why we use platelets and PRP in regenerative medicine, how to prepare and to control PRP, and what are the current recommendations in this field. So let's begin with the regenerative medicine. In fact, there is 2 different kinds of regenerative medicine. One part of regenerative medicine is what you see on this slide. So you can see a very a complex and serious disease, heart failure, burn. Here it's a newborn with immune deficiency. And so we have a part of regenerative medicine with rare and serious disease. And we have to produce a lot of stem cells, so it's very expensive. Sometimes we have a problem of immunogenicity because we are not using autologous cells. You need to do all that to make clinical trial, and you are in the field of ATMP, which is Advanced Therapy Medicinal Product, and you need to prepare your product in what we call a good manufacturing practice facility. And on the other side, we have another kind of regenerative medicine. And this is the purpose of my talk. We have what we call the point of care regenerative medicine. It has been developed by surgeons. It's more simple. It's point of care. You can do that during surgery or during consultation. It's autologous, so no immune problem. And you need to use some adapted medical device. And when you go through the history, you can see that the main product we use in point of care regenerative medicine, all the pioneers in the field have been surgeons. So adipose tissue, you may all know Sidney Coleman that have developed the therapeutic use of fat with the lipostructure. A French surgeon, Philippe Hernigou, is an orthopedic surgeon, described very clearly how to use bone marrow concentrate for orthopedic purpose. And this is the topic of today. Robert Marx is a maxillofacial surgeon, and with blood, he was the first to describe very clearly how to use the platelet, how to use the PRP for therapeutic use. And when you go through this surgeon pioneer paper, you can see that they have procedures that are very standardized. They describe all the steps. They have scientific publication. They have biological data, and they have objective assessment. So now let's focus on platelets and PRP. So platelets is what we call a multi-talented cells. Why? Because in fact, you can see the platelets, they are here, surrounded by a red circle. So they are very small cells, only 2 to 3 micron, and they are a reservoir of growth factors. The main growth factors are VEGF, EGF, FGF, TGF-beta, PDGF, and IGF. And all these growth factors, they participate to the healing and the regeneration and the reparation of the tissue. That's why there is such a huge interest of platelet in regenerative medicine. It's important to have in mind that in fact, platelets are only 5 to 6% of the whole blood initially. And so I like also this term, platelet is a factory of multiple bioactive molecules. And this factory in human physiology is the starting point of each healing process in human physiology. So the first time the word PRP was used was 50 years ago in scientific literature. More or less 30 years ago, we begin to use PRP in human in open heart surgery. And you can see that the idea that PRP and fibrin gel could be interesting for orthopedic use was in 1988, where we have a paper with a fibrin gel that can be used for medical repair in dog. But as I told you, the father of PRP technique is Robert Marx. He is maxillofacial surgeon. And in this pioneer paper, you can see that he's very precise about the preparation, the quality control of what he does. He was doing platelet count on each patient. He has an hypothesis about the quantity of growth factor in each platelets, and he has a very scientific conclusion. He wants to have 1 million of platelet by microliter in a 5 cc final volume for his use, which was reconstruction of the jaw. But it was you know, 20 years ago. And normally time is promoting innovation. You have here this picture about in 20 years, the size of the mobile phone is decreasing, but it's not really the case in PRP world. Why? Because we all know that technological improvement is an industrial leitmotif, but surprisingly, the description of the PRP used for treatment has finally regressed as compared with Mark's pioneering work. And when you go in detail, you can see that we have a lot of scientific publication about PRP, but the majority of them, you don't have any description of the PRP used, and very few of them characterize the injecting PRP. So it's still popular. We have more or less 1,000 papers per year in a lot of different indication and specialty. We have a randomized clinical trial, which is increasing, but we have main weakness. We don't know the composition of the PRP which is injected. And finally, when you go in the most serious paper in the field of orthopedics, what they say is that finally we have one only consensus in this field, is just to say that we don't have consensus. And we have a lot of papers that says now we need to go in the right way, in the way of quality control, trying to describe clearly what we are doing when we are doing PRP procedure. That we need for future study to improve the characterization of active elements, to standardize the concentration of active molecule, to improve national and international collaboration, and also to collaborate with governing bodies to promote scientific advancement. And we have also one problem is we have a lot of different denominations in this field. You can talk about PRP, sometime about PRGF, plasma-rich growth factor. If you activate the PRP with calcium chloride, sometimes you can have fibrin-rich platelet, which is this semi-solid fibrin gel. The concentration in leukocyte, I will come back on that, is also important. So you have a lot of different definitions. I'm trying to explain you how you can differentiate all of them. The first question you have to have in mind is, are you using an anticoagulant? If the answer is no, and then you are making a centrifugation, you will obtain fibrin-rich platelet, which is called also PRF. If you have anticoagulant and then you make a centrifugation, if you want to properly classify your PRP, you need to make a cell count to know if your PRP is pure or if it's a PRP rich in leukocytes. And before injection, you have 3 different ways of activation. Either no activation, which is the non-activated PRP, and the platelet will release their growth factor in contact to the tissue, or you can make activated PRP. If you've mixed your PRP with calcium chloride, then you will have a suspension of growth factor, and you can also obtain a PRP gel if you mix with calcium chloride plus thrombin. And you have something which is more solid, which looks like to PRF. So let's move to the preparation of PRP. In Europe, to prepare PRP, we have to use a dedicated medical device to prepare this PRP and to inject the PRP to the patient. We have more or less in Europe, maybe 30 medical devices available. You have here some brands, they are all different, and I will go through that and show the big heterogeneity linked to a PRP device. I like this picture because it was in a workshop, in a congress. We take one single blood from one donor, and we prepare PRP from 8 different devices from 8 different companies. And you can easily understand that this PRP is different from this one, is different from this one, and is different from this bloody one PRP. So we have a problem in the physician mind. These products are gathered under the same term, which is PRP. And I like to make this comparison that PRP is like apple. You have here 5 apples. These products are gathered under the term apples, but in fact, they are different products. It's exactly the same thing with PRP. So I will try to explain you the different kind of PRP first from a technical aspect. This is a review we have recently published in my department. We have made a big analysis where we have checked the promotional brochures, the scientific articles, the company websites, and we have tried to understand what are all the different types of PRP device. And we begin to classify them in three big families. The first family is the family of the vacuum tubes. You have some of them with separating gel, and then when you make the centrifugation, the gel is coming between the PRP and the red blood cells part, and then you have to mix it to have platelets inside your plasma part. And you have also some basics tubes without separating gels. So you can see that we have 9 commercial systems for that and 6 for this. Second types of blood harvesting and PRP device, you make the blood harvesting in a syringe, and this syringe can be centrifuged immediately. We have 6 devices in this family. Then you transfer the syringe in a secondary disposable. For example, this is the case with the iTissue FIDIA device you can see here. And this is the family of medical device which is the most represented in the PRP world. And you have also something which is not so much represented. You make the harvesting in a syringe and you transfer in an automated device, and you have a button and everything is done by the device. It's very expensive, and you have only 3 devices like that. And last one, there is one device which looks like 2 bags like you see in blood center, where you can collect and centrifuge directly the bag. So this was for the preparation. You have a lot of PRP device, and we have a problem is that all these PRP device will give different biological products. It's well described in the scientific literature. This paper you have there, they describe that all PRP device will give different biological products. And why it's important? It's important because now when you go to PubMed and you check the importance of the composition of PRP, it's clear that the composition of your PRP can influence the clinical benefit for the patient. You have here just a few selection of the papers that are going in this way, but you can see that, for example, on tendon cells, leukocyte-rich PRP is more pro-inflammatory. That here, it was also tendon, if it's too much pure PRP, you can have formation of excessive scar tissue. And here in a clinical trial, they say that leukocyte pure PRP show improved outcome compared with hyaluronic acid, and that, for example, adverse reactions were not related to the presence of leukocytes. So the composition can influence the clinical outcome. So you need to understand the PRP you are using. And to understand that, you need to know the good tools and the good biological parameters. So historically, Robert Marx says that PRP is defined as a suspension of platelet in plasma characterized by a platelet concentration higher than the original blood collected. Same thing with leukocytes. If leukocyte count is increased when compared to blood level, we are talking about leukocyte-rich PRP. And conversely, if leukocyte count is decreased, we are talking about pure PRP. So this factor, the platelet increase factor, the leukocytes increase factor, is what you see in the promotional brochure from the manufacturer device. And they have begun, all these manufacturers, they have begun a race to say, I have the highest platelet increase factor. You can see what I have found, 11 times, 12 times, 7 times, 7 times, 8 times. And this was a mistake because in fact, this parameter is not a good parameter to characterize clearly your PRP. Why? Because these parameters, they do not take into account the volume of PRP obtained. They do not talk about the red blood cells. They do not take the PRP as a global product, and they are not talking about the efficiency of the device, which what we call the recovery rate in platelets. That's why we have different new parameters. And so you have to have a global view of the PRP you are using. You have to know the relative composition of PRP, which is the percentage of platelets compared to white blood cells compared to red blood cells, the recovery rate in platelets, the remaining percentage of platelets in PRP from initial whole blood, and also the dose of injected platelet, like with any drugs you are using, you know the dose, here you need to know the dose. And these biological parameters, they are described in 7 different biological classifications. You can see that some parameters are similar in different classification, but we have a problem even if we have same parameter. For example, in this classification and this one, they are giving different threshold. So it's difficult to understand and difficult to use. This different biological classification, they describe 13 different biological parameters. The thresholds are different. None of them have been adopted. They have been built to simplify the field, but finally they have complexified the field. But one thing is very important. You need to classify your PRP, no matter the classification you use, to have a cell count both for blood and PRP. For how to make cell count, you have 2 ways. Either you can send to a lab, to an external lab. It will take time, and 1 or 2 days after that, you can have the cell count on blood and PRP. Or you can have a miniature cell counter like the Oriba Micros, and you have the result within 1 minute only. Now I move to the biological part, because when we have done this extensive review, we have checked in PubMed if we have biological data. And in fact, what we have shown that from the 50 PRP described, the 50 PRP devices we have found from a technical use, only 14 gets biological data on PubMed. Some of them I've described many times, so it corresponds to 36 PRP preparation. And what you will see here is completely amazing. So this is from each family, how many of the brands have been described. If you go through this paper, you have all the detailed data, but I will show you some graphics. And this is the big heterogeneity you can see regarding, for example, the increase factor of platelet. You can see that some of them, they are not even able to reach increase factor of 1. It means, in fact, they are not PRP. Some of them, they are going to 12, and you have a huge heterogeneity. Same thing for leukocyte. You can see that finally, the majority of the PRP device, they provide leukocyte-rich PRP, and only few of them are able to provide leukocyte-pure PRP. Regarding the purity, very important. We have only 7 from the 36 preparation we have described that have a purity of 90%. And we have 10 from 36 preparation. In fact, they provide more red blood cells to inject than platelets. And you can see that even this PRP preparation, they give only 5% of platelets, the same thing that in blood. So you are buying a device, and in fact, you have a product, you have buying a device to extract platelets, and finally, you have a product, a final PRP, which correspond to blood. And regarding the recovery rate, the capacity of the device to collect the maximum of platelet, you can see that only 1 device was able to collect more than 90% of the platelets, and that 11 from 36 PR preparation were not able to collect more than 50% of the platelets. That's why we have now recommendation from a scientific society. And first, I want to, because I won't go today too much through the clinical field, because we have a dedicated webinar on dermatology, urogynecology, and orthopedics, but just to explain you that PRP is an inescapable product. You will use PRP in your field. When we go in, this publication is only 1 month ago. We have already 132 studies that have been classified in 8 different specialties that provide data from level 1 and level 2 evidence-based medicine. The most represented field is musculoskeletal with tendinopathy, osteoarthritis, but also in cosmetic and also in oral and maxillofacial surgery. So it becomes really, we now have a lot of data in a lot of field. This is the truth. This is a study from only 1 month. So regarding recommendations, that's why we need recommendation, because it's beginning to be really, really popular. And we have the first two societies that have provided recommendation is the very serious International Society on Thrombosis and Hemostasis 2 years ago, and the American Academy of Orthopedic Surgery. The EASTH say in its conclusion, we have a popular strategy we can use in many clinical scenarios. It's cost effective, it's minimally invasive, and it's safe. Only advantages, but we need to improve the knowledge about the content and the quality control of the platelet preparation to ensure clear correlation between the product and the outcomes. And we also need to improve our knowledge on the mechanism of action of platelet tissue regeneration, and optimal platelet preparation may help to elucidate the best combination of bioactive factors to achieve maximal regenerative activity. Then the US orthopedic surgeon, they have made 2 very interesting recommendations in the field of orthopedics and in the field of PRP. So first is they have defined 23 parameters that you need to report when you are doing PRP. And what is very interesting, you have things about the injury, or you will inject, but there is more or less 9 or 10 items on the whole blood processing, the whole blood characteristics, the PRP processing, the PRP characteristics, and if you activate or not. So there is a lot of things on the preparation. The majority of the parameters you need to provide are about the PRP preparation. And second point, they say, okay, we won't come back to complex clinical trial. We know that PRP is used a lot, but please try to have efficacy registry. They say post-market monitoring registry, trying to understand the correlation between the biology and the clinical outcome. So this was the 2 first recommendations that appears, and since 2 years, 4 others recommendation appears from the French Sports Society, one from the French speaking experts, one from the German speaking experts, and one in the field of alopecia and wood healings, which is called the Hermes Society. So how can we follow this recommendation? It's not so easy, because if you are a physician alone, it's expensive. You have to buy a counter, a software, you have to have a maintenance of device, you have to have an expertise in the field, and sometimes it's difficult to take advantage of the data you will get. So some people manage to do that, and you will have, for example, in the session, Patrick Yam, Sophie Menkes, which are speakers in the following session, that have managed to do that. So it's very interesting to talk with them, but it's a few proportion of people. And what is now appearing is dedicated center with trained staff, mutualization of expensive technology, They have an expertise to build registry and use data. They make scientific publication, and they provide qualified regenerative product to any physician and patient at an affordable costs. And it's not science fiction. It does exist in US. You have Regenex, Regenerative Medicine Service of New York, True Doors, Center of Excellence. We have just launched one here in the south of France, in Marseille, which is called Remedex, Regenerative Medicine Department of Excellence. So probably this is the future of PRP and regenerative medicine therapy. But if you are here, you're interested by PRP, and I like this this picture and this to compare PRP to a tornado. Why? Because we have scientific data. We don't have so much regulation. We have the lobbying of manufacturer device. It can be used in many indications. Is fashionable, it's natural, biologic, and you have competitor physicians that are already users. So you will go to use PRP because this is a tornado that will go in any specialty. The question is, how will you go to PRP? Will you choose the red pill with manual preparation, bad condition, no quality control, no follow-up of the recommendation, or will you choose the blue pill? Precise protocol, standardized protocol, validated indication, quality control, follow-up of recommendation. So my conclusion of this talk, this is not my last slide, I have just one after that. It's not 20 years that PRP is used in this field. The initial description of Marx was more accurate than the current randomized clinical trial using PRP. It's very promising, but it's still debated because we don't know what we are injecting. The majority of the device don't have available biological characterization in index publication. And PRP is not, it's just an umbrella term, but which in fact is gathering dozens of different products. We still don't know exactly the clear impact of red blood cells and leukocytes on efficacy. We don't know which is the right dose. And we all know that dose of active drugs have been studied in medical field for drugs development for many, many years. Why it's not the case in PRP? We know that biology is important because we have already 7 biological classifications, but nobody is able to use them. And we have this international recommendation that suggests a systematic biological characterization of PRP and efficacy registry, but it's difficult and expensive to set up at the individual level. What are the perspectives? Center of Excellence, probably with staff, material, software. The goal is to make an homogenization of practice and to follow up the international recommendation. And probably we need to work together between industrial, hospital, research unit, private practitioner, and scientific society to optimize patient care. I will finish with, these 3 different citation from an inspiring physician, doctor, data scientist. One from my father, which is very important. When you are making formation, there is 2 things which are very, very important. So people who teach must accurately describe each operative step down the tiniest detail. We must be obsessed with detail. And so people who does must strictly follow the indicated technique. The technique is a liturgy which obliges any failure to be a mortal sin. Second point from Dr. Odette Choseov, who is sitting his friend Zayan Suleiman. He says, if you want an ID, open a notebook. And my recommendation, if you want to begin PRP, begin by to read the paper of Robert Marx 20 years ago. This is the first point. And the last one, if you go to this field, Edward Deming is a data scientist, he says that without data, you are finally just another person with an opinion. So that's why try to collect data, clinical, biological, if you want to go in this field. Thank you for your attention. Voilà, vas-y.
Okay, now I want to speak about indication, and we will have 3 training sessions. The first one will be the dermatologic, 20th of June. We will talk about rejuvenation, stretch mark, alopecia, and acne scar. The second one will be 27th of June about female and male genital area, Peyronie disease, erectile dysfunction, dryness, itching, burning pain, dyspareunia, and G-spot. And the last one will be on orthopedic and sport medicine, wrist, knee, Achilles tendon, and that is the team we have. Sophie Menkes with Switzerland, Hervé Collado within France, Robin Alves within Portugal, Patrick Yam within Canada, and Professor Florence Sabatier, who is the scientist of the team and who is doing all the bibliography, and we bring us a lot of new information. We want to share with you all the things we learned during the last 10 years, and we will be very happy if you are to this 3 course in function of your specialty. Thank you very much. And now I think it's a part of question and answer, and sure. I give the floor to the organizers Thank you.
Thank you very much, Professor Magalon, and thank you very much, Dr. Jeremy. That was a very insightful lecture that you just given. Now we will go ahead to take some time for questions right now. Just a reminder, doctors, ladies and gentlemen, please be sure to type your questions into the question box in your control panel. Again, look around. If you haven't really found the Q&A control box, just look around. It's either on the top of your screen or on the bottom of your screen, right? So, Prof, it looks like we do have quite a number of questions. Let's start with, what we have done is that we have actually consolidated some of the, and then we combine some of the questions who are similar. The first question that our participant has is regarding about the PRP. Must it always be active, the plasma? Must it always be activated?
This is a good question. In fact, there is no answer to that, because you have 2 different products. If you do not activate, you have platelets, which are fine, we have good quality, you inject and they release the growth factor. If you activate, you have suspension of growth factor before the injection. And we don't have comparative study for all the indication we have talked today that are comparing activated versus non-activated. What I can share is our personal experience. We prefer not to activate. Why? Because to activate is one more step in the preparation, and we want to limit the step. We want to try to go quickly first. The second point is when you think to the physiology of platelets and how platelets are working. When you have a healing process in the body, it's not growth factor which are coming. It's the platelets that come to the tissue and they are activated and they release growth factor. So that's why we prefer not to activate. We inject them and we think they will do the job naturally.
All right, thank you. Thank you, Dr. Jeremy. And there was also another question that if it was going to be activated, what are some of the ways to activate the plasma?
Can you repeat?
So the question, the second part of the question is that if we are to activate the plasma, what are some of the ways to activate those plasma?
There are 2 basic different ways. The first is you mix your PRP syringe with calcium chloride. So there is a ratio to respect that I don't remember exactly. And when you mix, then you can, the process of activation will begin, and you have to inject quickly if you still want to have a liquid product. But the platelets have begun to be activated. The second way you can activate platelets is to get a gel, is to get a PRP gel. And here you need to mix with both calcium chloride and also with thrombin. So to get thrombin from a patient, you need to have another blood collection, another blood collection and another device. So it's not so easy. And it's to finally get a kind of a paste of a semi-solid product, which can be used not for inject, because you cannot inject it, but for open surgery, for example, for maxillofacial surgeries, it's possible.
Right. That is the second part to that question as well, Dr. Jeremy. This question comes from Stephanie. So Dr. Stephanie is asking that he has seen some people doing 2 centrifugation, one of the whole blood, then the other one yellow PRP to get more concentrated PRP. Is this necessary if we are going to inject all of the PRP?
No, this is not necessary. This is one of the problem we get in as I told in my presentation. This is one of the problem we get with the manufacturers and with the protocol from manufacturers. Why? Because as I told you, the parameters the manufacturers are trying to sell to the physician is to say, I have the PRP with the highest PRP, with the highest platelet concentration. So what they recommend, they say, okay, you collect with the first centrifugation of all your platelet, then you make a second centrifugation. This second centrifugation, you will have all the platelet at the end, at the bottom of the tubes. You will remove the upper part that we call the PPP, the plasma pour, the platelet pour plasma. And then you will have a small volume, very small, with a very high concentration because you have decreased the volume. But for me, this is not necessary. You have to have in mind that finally, for each indication, for NeoA, alopecia, for tendinitis, for gynecology, we will have different product, different volume, different concentration.
Right. Sorry. The following question asks that, how do we know if a PRP is good? The quality of the PRP, how do we know if it is good?
There is no, so I think I have seen a question about the color. That's right, that the color of the PRP is the first thing. If your PRP is completely red, bloody, this is not a good PRP. First point. But if you want to know the quality, if your PRP is good, you have only one way. You have to count what you are doing. Yeah. To know the quality, you have to do quality control.
And the next question, when we use a PRP gel, fibrin-rich platelet, are they same function or different? So this is the question from Dr. Rani. Yeah.
If I understand, the question is the difference between PRP gel and platelet-rich fibrin. This is the question?
Yes, I believe it should be. Are they the same in terms of function or different?
It's like for the question, when you use okay, I have the, when we use non-activated, so all these products are different. As I have already answered to the question, non-activated PRP versus activated PRP. And between PRP gel and fibrin-rich platelets, we know that these products are different and that the structure of the fibrin is not the same in these two products. So I don't know which is the most efficient between these two solid products. What I can tell you from my experience is that when you are doing, if you want a big, a big PRP, if you want a big structure, it's better to do PRP gel because you can prepare a big amount of PRP, you can activate, and you can have something which is like that, for example, for a wound, whereas when you are doing a PRF, you have something which is very PRF is done with a lab tube, and you have something which is from the size of my nails, for example. So maybe choose you should choose based on the size of the gel you want to obtain.
Right. So questions are coming in really, really actively. Dr. Jeremy, there are more questions for you. The next question will be, if we don't use calcium chloride mix with PRP, what would happen? And the effect of PRP without calcium chloride, would that be different?
So if you don't use it, as I told you, I prefer not to use calcium chloride, because when you inject the platelets, they find inside our body activators. There is a lot of activators in platelets inside the body. Collagen is an activator of platelets, and we have collagen everywhere in the body. Calcium is an activator, and we have also calcium in the body. So I prefer not to mix with calcium chloride. We inject, and I don't know what is going on in the body, because I can see that, but the hypothesis is once the platelets, they have found the activator, calcium or collagen, they release their growth factor.
So if there is no calcium chloride, can you use, that is another question.
What is important is to have to have an anticoagulant when you are making the blood harvesting. This is also important, to have a liquid product.
Mm-hmm. Right. So the next question for me, with so many devices available, how do we choose which is the best device to go for? And what are the criteria to consider?
This is a very, very good question. In fact, I tell you the truth, it's difficult to consider that one device will be able to work on all and to satisfy all the indication of PRP. So first, think to what indications you want to treat. First, do you want to treat a tendon where you need only 3 cc? Do you want to treat alopecia where you could need it's possible you need 20 cc? Do you want something for a knee where it's good to put 10 to 15 cc? So first, try to think a full face, I don't know, 20 cc for a full face. So first, try to think to the good indication, first point. And to be sure, because sometimes with some PRP device, you collect 2 cc. And the manufacturers, they say, yes, it's good. You can put this 2 cc in the knee, it will work. But I can tell you that it's not the same thing to put 2 cc in the knee and 15 cc in the knee. You won't have the same result. You will have better result with 15 cc. So first, define your indication. Then try to know the quality, the purity of your device. Do you have contamination with red blood cells, with leukocytes? Because for example, in knee, skin, for alopecia, we try to avoid red blood cells and leukocytes. We have scientific data for that. In tendons, it's not so clear. In tendons, it seems that maybe leukocytes could be interesting. So you need to define your indication, trying to check in this indication what is the best formulation, and then you choose a medical device. And the best way is to control, once you have your medical device, that you have the right PRP formulation.
Thank you, Dr. Jeremy. There are also a couple of more questions when it comes to PRP. What are the side effects of platelet-poor plasma that we have to separate it from platelet-rich plasma?
This is a good question again. There is no side effect, neither from PPP and from PRP. The only reason you have to move, but I never, no, more or less, I never remove PPP. It's just sometimes the manufacturers, they say, you have to remove the upper part. It's just to get a more concentrated PRP to market that. But there is no side effect at all, neither from PPP and from PRP. This is autologous procedure. So, and I agree that if, for example, if you are think in volume, it's better to think in volume. If you want to treat, as I told you, a full face, and you want to get 10 cc, keep the upper part of your plasma. This is better.
Right. And there is another one more, which is relatively interesting as well. In terms of growth factor, is PRP more superior than stem cell?
This is a good question. I think we have, I don't have in mind clinical, I don't have in mind scientific studies that have compared the growth factor you get from a PRP and you get from stem cells. I think, I don't know in quantity, I think that in stem cells, and mainly in mesenchymal stem cell, you have more different growth factor. I think, yes, you have more different growth factor in stem cells. In terms of quantity, I don't know. This is a very good question. The big difference between stem cells and PRP is stem cells, you have a nucleus. It means that potentially, and I say potentially, the cells can divide. With platelets, you don't have nucleus. Platelets, they cannot divide. They are just the reservoir, the factory of growth factor.
Right. There was another regarding about calcium chloride that we missed out. Dr. Lee was asking, if there is no calcium chloride, can we use calcium gluconate?
Yeah, I think you can. If you want to activate, calcium gluconate should work also. You just have to have calcium.
Right. So let's move on to the next question. When using non-activated PRP, how long can you keep it before injecting, except for dermatology purpose or for intraarticular, like the knee?
We have data. We get from the eye tissue device from FIDIA, where we have shown that once the PRP is ready, non-activated, we have checked the quality of the platelet 3 hours after, and the quality is still good. So what we do in our department is that we try to inject as soon as possible, but we know that we can wait. If we have to wait, we can wait 3 hours. We don't have data after 3 hours.
Right. So following that question, we have quite a number of questions regarding about the protocol you follow, Dr. Jeremy. What is the protocol that you follow for PRP production? How many RPM? How many minutes do you spin the specimen? And there's also another one that is also coming into the same question, which asks, does the spinning time and the speed affect the PRP preparation and its effectiveness?
So regarding the protocol, I use, you know, in France, you have to use a medical device. So I don't have my own parameters. I follow the parameter of the manufacturers. But before to begin, I check if the PRP I get is of quality. And in our center here in Marseille, we have different protocols for different injection sites. We don't have the same exactly protocol for tendons, for knee-OA, and for example, for uro and gynecology. So I cannot give a number for that. This is the first point. The second point, what was the second part of the question?
Just the spinning time and the
spinning,
speed.
yeah. Yes. In fact, from our experience, what affects the most the platelet is when you do 2 centrifugation. When you do 1 centrifugation, and you should not go more than, let's say, 400 to maybe not more than 1000 G, and with one centrifugation, I would say this is okay. You do not affect too much the platelet. But if you repeat that 2 times, and for example, 2 times 10 minutes, you begin to affect the platelet.
All right. So let me just quickly go through. There is another one. In aesthetic treatments, doctors inject PRP for rejuvenation. However, I have seen some doctors add sodium bicarb into the PRP to reduce the pain while injecting. Will sodium bicarb reduce the efficacy of PRP?
I don't know that. I know this procedure because this procedure is done to adjust the pH of the PRP because sometimes because regarding based on the anticoagulant you use, you can have final pH of PRP which is acid, and you can put some sodium bicarbonate to have a more neutral PRP. But I don't have the answer about if this sodium bicarbonate reduce the efficacy of PRP. I don't know. I don't know any publication about that. What I more or less in the same way I can say that what we know is local anesthetic like ropivacaine, for example. If it's in contact directly with platelet, it affects the capacity of the platelets to release growth factor.
Right. So we due to the time, we're going to take a couple more. We're just going to take about 3 more questions. And there are a few technical questions regarding about PRP. What tubes are better for PRP preparation? Is the plain tube or tubes with anticoagulant like sodium citrate?
If you want to prepare with tube, as I told you, in Europe, this is forbidden. You cannot go to the lab that is doing medical analysis and to buy lab tube to prepare PRP. It's not possible. But if it's the case, if you want PRP, yes, you want to have tubes with anticoagulant. This is if you have tubes without anticoagulant, you will not obtain plasma, you will obtain serum. Serum, you have no cells in it, you have no platelets, and you will have the yellow part, then the red blood cells, and between the yellow part, which is the serum, and the red blood cells, which is the blood, you will have the fibrin, a fibrin gel, which is called the PRF.
Right. So a few more questions are asking whether or not we can mix the PRP with, number 1, fillers, or would that be all right also that if you add vitamin C to PRP, is there any advantage to this type of addition, and would it affect the of the platelet degranulation?
Tu veux répondre peut-être sur les mélanges?
Yes, it's possible to mix PRP with other products. You can mix with filler, and the most popular is hyaluronic acid. We mix also very often PRP with microfat. We mix with emulsified fat, and we need to find the good percentage. It seems that the good percentage is 20% of PRP, no more. And you have you have different products. Each one of the products, probably we will organize a teaching course on a product derived from fat and mixture, and we can explain what happens when you mix with other products. Yes, all is possible. And it's not dangerous, it's no risk.
Right. Thank you, Professor. So we will take one last question due to the time. And the last question will be, what are the contraindications for PRP?
In fact, there are not so much contraindication for PRP. what we try to say to the patient is trying to avoid any drugs that could inhibit platelet function, like aspirin, like non-steroidal anti-inflammatory drugs. What is a good question to ask to the patient is, do you have any known platelet disease, because there are some platelet disease, or do you have any problem of a thrombopenia, for example? But there is not so much contraindication. Sometimes, but I would say that things are changing. Sometimes people prefer not to inject PRP when people have, severe chronic disease, but it's a debate because in this case PRP could also work, but.
All right. So it looks like we've covered most of our questions. Due to the limitation of time, we will have to end the Q&A session over here. Professor Magalon and Dr. Jeremy, is there anything else that you want to cover before we move on to the next agenda of today's session?
Yes, I want just, I have seen on the question is many questions about the treatment of wounds and burns, and probably one day we can talk about how to treat burns and wounds with PRP, because that is possible, and Jeremy can explain how we can do PRP gel and to have some dressing, and that also is a field which is very interesting, and we can work on this subject one day. If for people who are interested by acute lesion and not chronic lesion. And Jeremy, if you have something to add?
Yeah, I have to say that the questions were very interesting. We're not able to answer to everything because time is running, but I invite you to join the next session because it was very interesting. It was very insightful session. So do not hesitate to join us for the following webinar.
Thank you very much, Professor Magalon and Dr. Jeremy. The session was really insightful and it was really informative. Thank you very much. And for ladies and gentlemen who are still staying with us, the entire lecture, including the Q&A, is being recorded. You can, if you would like to revisit some of these answers to the questions, you can always log into our website to view the session again. Right? So following today's introduction of the application of PRP, this month we at FED are excited to showcase more interesting courses on PRP application as what Professor Magalon was sharing earlier. As per highlighted in the very beginning, there are 3 other exciting consecutive virtual sessions on additional application of PRP. The very first one is going on indeed in 7 days, 20th of June, in dermatology practice, where we look into using PRP for facial rejuvenation, acne scars, striae, and alopecia. So the second session will be on the 27th of June. Very interesting application of PRP for female and male genital area, namely targeting itching, burning, dryness, pain, G-spot, Peyronie's disease, and erectile dysfunction. The third of the full series will be held on the 4th of July with the use of PRP for orthopedic and sports medicine, targeting joint treatment and tendinopathy. On behalf of PETS and our main sponsor, Fidia Pharma, and our gold sponsor, Horiba Medical, we would like to say thank you for joining us today, and we hope to see you next time. Yeah. Good morning.
Thank you, Dr. Jeremy.
Good afternoon, and good evening once again, ladies and gentlemen.
Thank you very much.
Thank you, everyone. Thank you, Professor. Thank you, Dr. Jeremy.